Good evening, clinicians and all guests on the call today. It is my absolute pleasure to welcome you to today's session. My name is Ken Agutu, and together with my colleague, Angela Wairimu, we will facilitate today's proceedings. Angela?
Hello, everyone. Welcome on board this session.
Thank you. Today's session is part of the Tele-education on non-communicable diseases to equip clinicians in Africa. In short, Project TeNEC Africa, which is an initiative between Boehringer Ingelheim together with Ashoka and Making More Health and 3 social enterprises from Africa: the Chronic Drugs Medical Scheme, CDMS in short, and Jacaranda Maternity, both from Kenya, and mDoc from Nigeria. The intention of these sessions is to create cross-country peer-to-peer learning by bringing together health workers from across the continent on a platform where they can share knowledge and experience on a wide range of health conditions through talks and case presentations from subject matter experts and having experts answer questions from participants. Right now, Nigeria and Kenya will act as the initial hubs, with plans to scale the initiative right across Africa. We have over 100 participating hospitals from across the continent. In Kenya, we have partnered with the Rural Private Hospital Association of Kenya and other partners who have been kind enough to join us this afternoon. We also have a great portfolio of experts from Africa, both those residing within and outside the continent, and experts from other continents. Please take note that the project TeNEC Africa leverages the ECHO model. We collect registration, participation, questions and answers, chat comments, and poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel. This data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and also to inform new initiatives. Sorry. This session will be recorded. We will be sharing a PDF version of the slides after the session. So I'll go quickly to the participation tips, which are our online protocols. Please ensure that your camera is on. The facilitator will unmute you when you need to speak, but where possible, if you need to ask a question, please try and use the raise hand function on Zoom. As you register yourself, please rename yourself by putting down your name and the health facility you come from. Introduce yourself on the chat, giving your name, your organization, and if you're from a health facility, and also state how many people are using your gadget. Where possible, have your video on if your bandwidth allows. Please remain muted when not speaking. If you're given the opportunity to say something, then the facilitator will very quickly unmute you. Use the raise hand feature in Zoom when you want to ask a question, or better still, write out your question on the chat. Our technical support team is available to help you on any technological issues, and the contacts of Habil and Robert are at the bottom of the screen, just in case you need to reach them during this call. The session is projected to take 1.5 hours, and you can now see the agenda on the screen. You can also access the TeNEC organizations, the partner organizations, on social media, and the handles will be displayed now. Thank you. So at this point, it is my absolute honor to introduce the CEO of the Chronic Drugs Medical Scheme, CDMS, who are hosting today's session, Mr. Sam Agutu, to say a word, and also to invite representatives of our partners to introduce themselves. Sam.
Good afternoon for those of our colleagues in Nigeria. Good evening, those in Kenya. My name is Sam Agutu, and I am the founder and CEO of the Chronic Drugs Medical Scheme, or CDMS. We are a social enterprise that uses digital interventions to improve patient experience among low-income populations. We have partnered with the Rural Private Hospital Association, RUPHA, here in Kenya, which is a hospital member association with over 250 members. We have established almost reduce the cost of purchases to small rural hospitals. Now, under this program, the TeNEC program, we are working with RUPHA to identify and bridge human resource capacity gaps. We would like to thank our partners. I may just mention them: GIZ and Lab of Tomorrow, who have been with us on this journey for a long time, Boehringer Ingelheim, Making More Health, and Ashoka, the Rural Private Hospital Association, who are represented here, and while I hope Mr. Brian Lishenga, the chairman, will be able to say a word in a short while, and really the whole of the CDMS team. I invite Mr. Saharan Shah, who is the CEO of Jacaranda Maternity, to say a word. Thank you.
Thanks so much, Sam. Hi, everybody. My name is Saharan Shah. I'm the CEO of Jacaranda Maternity. Our vision is, as a chain of maternity hospitals, to provide high quality, affordable maternity care to communities we serve. And our mission is to become the largest chain of maternity hospitals in East Africa. Thank you so much and welcome. Looking forward to an enjoyable session. I'm now going to hand over to the CEO of mDoc, who is Nneka Mobison.
Over to you, Nneka. If Nneka is not in, or maybe Adora, you could.
Hello, everyone. I was speaking on mute. Apologies. I will be representing the CEO of mDoc today, Dr. Nneka Mobison. I am Adora Odukwe, a senior project manager with mDoc. mDoc is a digital company that provides self-care support to people with regular and chronic health needs. Neuroscience, quality technologies, data, and technology to do leverage model to build around areas care and this to non-communicable diseases. Of course, because across Africa, we're happy to be partnered with CDMS, Jacaranda. We're happy to partner with BI, the Making More Health Initiative, and Ashoka, the wonderful project. So we're happy to be here and look forward to a very exciting session.
Thank you very much, Adora. I'd like to welcome Dr. Brian Lishenga, Chairman of the Rural Private Hospital Association, to give us a word of welcome.
All right, good evening, everybody. Thank you, Sam, and the entire team. My name is Dr. Brian Lishenga. I'm the chairman of the Rural Private Hospital Association of Kenya. We are very happy to partner with you and to bring this important medical education to we have quite a number of our members who have joined us. So both clinicians and hospital directors, and we certainly look forward to the continued success of this project. Thank you.
Thank you very much, Brian. At this point, I would like to invite Mr. Nasir Katuramu or Dr. Chris Ibaya to say a word on behalf of Making More Health, BI and Ashoka.
Right, thank you very much, Samuel. My name is Nasir Katuramu. I work with Ashoka as a project manager for the Making More Health Accelerator program. On behalf of Making More Health, Ashoka, and Boehringer Ingelheim, would like to say how proud we are to be associated with this important initiative to strengthen healthcare systems in Africa by providing clinicians with capacity building, which is really important at the front lines. We'd like to thank very much Jacaranda Maternity, CDMS, as well as mDoc, who are really the ones that are spearheading this initiative and all this possible. Really excited about this session today, and thank you all for making the time to attend. I hope you find it valuable. Thank you very much.
Thank you very much, Nasir. I'd like to then back the facilitator back. Thank you.
Much, Sam, and thank you for the openness, for the wise words. I would like to continue reminding participants to introduce themselves on the chat. Please introduce yourselves on the chat. It is now time for us to post the pre-session quiz. There's a poll that's going to be posted on the screen, and I urge everyone to attempt the quiz. After the didactic presentation, we will repeat the quiz. Habil? Yes, please attempt the quiz. We only have a couple of minutes to complete this, so let's get going. Everyone on the call should attempt this except the didactic speaker.
Hello,
Hello, I think there's a small technical problem with the poll. We're trying to sort it out in a minute.
Thank you. As we sort that out, please, like I said, you're very welcome, everybody. It's really, really kind of you to be able to attend today's session. Try and introduce yourself on the chat, indicate which facility you are from, and how many of you are on that particular gadget. I'm very, very impressed. There's already 73 of us on the call, so we don't take it for granted that you found time to come for this very important session. Yes, I can see people introducing themselves. Welcome, Brian. Dali. Yep, thank you. I can see quite a number of people introducing themselves.
Okay.
If you welcome, Dennis. If you introduce yourself using your gadget like Galaxy, Oppo, iPhone, please rename yourself so that we have a name of a person or the facility from which you are joining us. Good to see all of you. So just give us a very short while. All right, the poll has been relaunched. So let's try very quickly and respond. Thank you so much for those who are already trying out the poll. Let's see the responses coming in. All right. Sam, please advise us if the poll results have come in. Habil? All right. Okay, thank you so much, everybody who's taken the poll. We will move on. And now it is time, we've closed the poll. It's now time to introduce our didactic speaker of the evening, Dr. Wafula Nalwa. Dr. Nalwa is a physician and a cardiologist with several years' experience. He is the founder and CEO and Chief Medical Officer of the Kisumu Heart Center, a specialist center for clinical, preventive, and rehabilitative cardiology and cardiometabolic medicine. He is a Bachelor of Medicine and Surgery graduate of the University of Nairobi. Dr. Wafula Nalwa also holds a Master of Medicine degree in internal medicine from the same university. He is also passionate about teaching, and he is also a holder of a fellowship in cardiology from the Yashoda Heart Institute of India. He has previously taught at Maseno University. His presentation will last 30 minutes. So will you all join me in welcoming Dr. Wafula Nalwa? Dr. Wafula Nalwa, the floor is yours. Karibu.
Hello, everyone.
Good evening.
Yeah, can you see me?
Yes, good evening, we can.
Good evening, we can see you well.
Thank you. So I will do a presentation on hypertension in sub-Saharan Africa, what we need to know, and some of the important things we need to do in terms of practice and even policy. Next slide. Hello.
We can hear you.
So this gives us, this gives us a snapshot of the burden of hypertension around the world. If you look at all the regions of the world, it's around 22%. However, in the least developed countries, you have accelerated development of cardiovascular disease because of demographic shift, nutritional transition, meaning that people who are living in rural areas, people who previously did not have access to certain risk factors, are now getting access to those risk factors and are developing hypertension. And so the least developed countries in South America, Africa, and Asia have a huge
Dr. Nalwa, you're muted.
Okay. This is a slide. This is a slide that highlights the disease burden in a place like northern Tanzania. If you look at the blue color up here, you will notice that chronic diseases are accounting for a significant portion of the burden of disease in a very, very rural part of northern Tanzania. Then there are issues that are complicating the cardiovascular disease burden. For example, COVID. You can see in that diagram there, down here you can see disease mortality, CVD prevalence, and hypertension prevalence. If you look at the first column, you can see pink. COVID mortality seems to track CVD prevalence and hypertension prevalence. And so areas that have a significant burden of NCDs look like they are going to be affected significantly by a number of these emerging challenges. And therefore, all facilities need to be aware and to be prepared and to invest in the management of hypertension. Now, in Africa, it has been found that elevated systolic blood pressure is a significant cause of mortality. Systolic blood pressure, anything above 140 is elevated blood pressure. And if it is tested on different occasions and remains elevated, it should not be excused. It needs to be diagnosed as hypertension. Elevated systolic pressure also accounts for more than half of the first-time acute stroke, and it's considered to be a modifiable risk factor for dementia. Of all adults that have been studied across the continent, it's found that about 55% of people older than 55 years have hypertension. And among those who are under that age group, around 30%. Therefore, it's a growing problem in poorer households, in rural populations, in younger people in whom it's more aggressive. And urbanization is not helping much, because the changing of the diets, the changing of the settings of physical activity are aggravating the situation. So what is the definition? Generally speaking, we talk about 140 over 90, or someone who is on treatment. But there are different groups of people who have had classified blood pressure. We have the Americans and we have the Europeans. And they have different cutoffs and gradings that we all need to be aware of. Just a minute, sorry. Am I doing the right presentation? Something seems to be amiss here, but no problem. Generally speaking, we talk about optimal blood pressure below 120 over 80, normal 120 to 129, high normal 130 to 139, and then we start grading it as grade 1, 140 and above, grade 2, 160 and above, and then 180 and above. And this is very important because we need to know that we need to be quite aggressive in treating hypertension, and every millimeter lowering of blood pressure is significant, has a mortality and morbidity benefit. There are determinants of hypertension. When you look at a group of people who have hypertension, when you look at communities of people who have hypertension, there are certain factors that you cannot change, and there are certain factors that you can change. So when we talk about age, sex, heredity, ethnicity, those are things you cannot change, and you must always capture them in the history when you are interacting with a patient. Or when you are considering a patient to have hypertension, you must always think about these factors. And then there are other modifiable risk factors that are related to lifestyle, including salt intake, sedentary lifestyle, mental stress, and the like. Types of hypertension. When you are managing a patient with hypertension, it's important to know that we have essential hypertension, which has no attributable cause. The most common factor related to essential hypertension is age and gender. But then we have other types of hypertension that are related to disease entities that a patient may have. For example, a patient who has hyperthyroidism, a patient who has chronic kidney disease, a patient who has a tumor. So whenever you find someone who has hypertension, you need to try and delineate. Is this patient having essential hypertension or secondary hypertension? Someone who develops very severe blood pressure under 35, for example, or above 55, for example, very high blood pressures, you may need to consider if they have a secondary cause of hypertension. And the secondary cause of hypertension on its own is a target for treatment. That's why you need to find out what is the underlying cause for it. Hello?
Yeah, Dr. Afula, you may now use our
yeah.
what we have, yes.
Yes, yes. Okay. So please scroll up, please scroll up. Okay. Again. So we've talked about essential and the determinants of blood pressure, modifiable and non-modifiable risk factors. It's important to always have this in mind when you are managing whichever patients that you have. Next slide, please. We've already addressed that. Next slide. So why do we worry about hypertension? Why do we worry about hypertension? This slide summarizes the reasons why we are concerned about hypertension. That uncontrolled blood pressure, elevated blood pressure, is associated with heart disease, it's associated with stroke, it's associated with myocardial damage and heart failure, it's associated with brain dysfunction and memory issues, it's associated with kidney disease, it's associated with blindness, it's associated with peripheral arterial disease, and therefore it's one of those issues that must be addressed significantly. Many times when we talk about medical complications, we do not give it the of what hypertension really is. If you look on level of your source of opportunity, if you have a stroke or heart failure, will not be able to engage in economic activities as should. Dependence. There's reverse of dependency. Providers start becoming dependent people. There's increased cost of care when you have complications. You can imagine the cost of that. And that cost of care is actually impoverishing families. Therefore, it's important to be very careful in making the diagnosis of hypertension, to be very careful in instituting appropriate treatment and timely titration to target for these patients. Next. So what do we need to do? What do patients need to do? What should be our approach to managing patients who have hypertension? There is a big component that is related to lifestyle. Studies that have been done in Kenya, for instance, among the Maasai community, who are a nomadic community and who used to trek large wide expanses of land. About 50 years ago, there was no documented case of hypertension, but their habitats have been invaded by urban areas. And right now, the prevalence of hypertension is very high, as highlighted in the northern Tanzania area, which is the territory that the Maasai used to traverse. And so issues to do with diet, salt content, alcohol intake, physical activity, mental stress that comes with urbanization and globalization, weight challenges, smoking, and even access to treatment are all factors that need to be addressed when you're dealing with hypertension. So what do we need to do? We need to change diet. We need to change our levels of physical activity and stress and manage a healthy body weight. Next. For medics, when we interact with our people, we need to assess and score them. So remember, we talked about hypertension. We talked about the stage of hypertension. Stage 1, 140 and above. Stage 2, 160 and above. Stage 3, over 180. You need to look at what kind of risk factors do these patients have. 1 to 2 risk factors or greater than 3 risk factors. Anytime you have greater than 3 risk factors in a patient who is in stage 1, and then it means that you need to consider them as high risk, depending on the blood pressure here. If you can look up here, compared to stage 1 and complicated hypertension. Then you have asymptomatic disease, and then you have stage 3 symptomatic disease. So any patient who has renal disease, has elevated blood pressure, you can see how we need to address them. We need to be very aggressive to lower that blood pressure. You have a patient who has cerebrovascular disease and kidney disease and long-standing diabetes. They become patients who are at very high risk of complications, and therefore they need to be managed quite aggressively. So scoring a patient, putting together the risk factors will help you to understand that patient and to be able to manage them. Now, to do this, it means that we must be able to empower our nurses. We need to empower medical officers and clinical officers. We need to reorient the training so that they can be able to understand what this is all about. Next. How do we then do assessment of patients practically? The first is history and examination. Every day in my practice, I see patients who have hypertension and have been told it is not so severe, it is not so high. Let us check for malaria, let us check for typhoid. It is never considered that hypertension on its own can cause patients to be unwell as they come to hospital. So always have it at the back of your mind in people who are older, who present with any nebulous symptom. Actually, these patients, in the examination, it needs to be part of the vital signs that are considered significantly. Secondly, we need to consider be able to score their cardiovascular risk and therefore to see how aggressively we need to manage them. If a patient comes with leg swelling, facial puffiness, or if a patient comes with features of thyroid disease, then investigate it. If a patient comes with heart disease or heart failure, you need to investigate it. If a patient comes with a stroke or a transient ischemic attack, you need to investigate it so that you understand the true state of that particular patient. Once you've listened to the history, you've examined, you've been able to distinguish between various factors, then you can propose a treatment for that particular patient. Next. So the most important thing you need to have is a blood pressure machine, a very good listening ear, and careful examination. Management of patients who have hypertension needs to be individualized. It needs to be looked at in the lens of cost and sustainability. Options available for treating people with hypertension include lifestyle, we've alluded to earlier, pharmacologic therapies, and there may be surgical interventions. Next. We have already alluded to these issues of weight, calorie restriction, salt restriction, increased fruit and vegetable consumption to help us with micronutrients and potassium, increased physical activity for cardiometabolic fitness and calorie management, quitting smoking and alcohol use, and management of social and occupational stressors. Next. Now, one of the ways I like to illustrate the approach to treating hypertension is to look at your own legs or your own hands or your own paired organs. That for you to be able to function optimally, you have the two paired organs, especially present may be introduced with one drug, but eventually they need to is not enough. You need to pair it with lifestyle management. So drug patients will end up requiring 2 or more agents. To add an agent, do not hesitate to up-titrate the dose of drugs that we have. Us to use. The main classes of medication behind diuretics or thiazide-like diuretics. We have calcium channel blockers. Calcium blockers include nifedipine, amlodipine, angiotensin converting enzyme inhibitors. We have angiotensin receptor blockers. So group I class. D, we have angiotensin, angiotensin converting enzyme inhibitors include drugs like enalapril. It's not, which in your countries you may find and group. Beta blockers include atenolol, carvedilol, bisoprolol. Mineralocorticoid drugs include dacton, eplerenone. So you need to know these classes of medication so that you can choose them accordingly. It's an important thing for us to know. There may be newer drugs in each of this. When you are selecting the drugs, it's important to consider cost and availability. Not the latest, not the most fancy name, but one that works. So is it available? Is it affordable for long-term use? You can use fixed dose combinations. For example, if a patient is on losartan and thiazide, you can reduce their pill burden by combining 2 drugs. You can consider what are called compelling indications. Indication means that those have particular value in surgeons and then to enjoy that. Diabetes develop it's important to consider the adverse events. Because you come looking a lot, ask yourself, is it the drug that is contributing? In elderly patients, electrolyte imbalance is important. If there's change in mentation, that means they are becoming more drowsy and the like. Ask yourself, there's an important factor also to consider is dose titration. Generally speaking, I see patients who come to see me with enalapril at 5 milligrams, for example. 5 milligrams is not, once a day is not sufficient to control markedly elevated blood pressure. You should be able to increase it to 10 and even to 20 in a day. All the way to 100. So I like to have a drug index close to me. Every time interacting with patients, I have a drug index I can refer to, or I might ensure that I'm able to titrate the doses correctly. This is some. This is part of the presentation of compelling indications. So Black patients will need a diuretic plus a calcium channel blocker in their treatment for effective treatment. You cannot use enalapril and lotion together. You are going to have side effects. Patients who have heart failure will need an SE inhibitor or an ARB, a diuretic based on their volume status. They may need a beta blocker, mineralocorticoid antagonist because of the mortality benefits. So you may need to combine them in heart failure. For chronic kidney disease, we've talked about the renoprotective effects of renin-angiotensin system inhibitors. And then patients who have diabetes should be generally treated like patients who do not have diabetes unless they have proteinuria, but there is a protective effect of SE inhibitors and ARBs. So there are compelling indications. Whenever a patient comes to you, ask yourself, what are the unique features that this patient has and which drug confers advantage, a therapeutic advantage. Next. Next slide, please. Looking at this slide, it gives us an indication, a snapshot of 10 targets that we need to have. Just like all of us, when we set off on a journey, we need to know where the look at this age bracket here, 18 to 65. If you can reach 130, for older patients, you may be a little liberal to 139. Is a fair target for all the patients. For various reasons, I have found it difficult to bring it to below 100. There are several barriers to blood pressure control, which we all need to be aware of. Access to treatment, reluctance to change lifestyle, failure to take medications as indicated, for whatever reason, lack of regular whether it's side effect of a drug, for example, erectile dysfunction, inertia, function of knowledge, communication barriers, or non-compliance to treatment, whatever it is that contribute to poor control. So we need to be aware of that. Next slide. There are also surgical interventions. We focus on them, but for thyroid disease, there is a solution. For adrenal tumors, there is solutions. Then there are policy interventions. I mean, sitting in a clinic or sitting in a hospital to manage hypertension is easy, but there are macro level issues that affect our ability to control pressure, that affect the incidence and prevalence of hypertension. For example, you look at a community and where you stay. Is there a place for children to stay fit and to control their weight? Are there safe roads for people to jog or to cycle? Are there safe neighborhoods for people to wake up early and do physical activity? When you go to the supermarket, who controls the amount of salt and sugar in food? How do we support people who want to stop alcohol or cigarettes? How many people know that 55% of people over 55 years have hypertension and something needs to be done? When was the last time you attended a seminar on hypertension funded by NGO or funded by a donor agency, you do not see a good pool of competent HR, and that's why I applaud Project TeNEC. Then cost-effective medications. There's a tendency for medical practitioners to run to the latest, which are more expensive medications. I have found pure delight in using cheaper older drugs to manage our patients and controlling their blood pressure. So access to cost-effective medications is important. At policy level, we need to ensure this is available. We need to increase awareness of disease. And then community engagement and participation in control. NCDs have looked like an elite group of conditions, but it's a big requirement communities to work together to conquer it. And I believe that we can do that. Thank you very much.
Thank you very much, Dr. Wafula, for this superb presentation. I'm sure we are all better informed. Clearly, nutrition plays a major role in the prevention and management of hypertension. Without further ado, I'd like to invite Mrs. Fumi Ijiwola, one of the hub experts and a nutritionist by profession, to share her thoughts with us. Over to you.
Okay, thank you very much. Good afternoon and good day all. This slide, as Dr. have already stated, that nutrition is playing a very great role and is a teamwork, and it also involves us also sending these patients down to dietitians so that they can see them as a whole, and then so that we can manage the patient well. So because of this, we just have few points. I don't know if you have the slide with you, Ma. Hello, can you hear me?
Yes, I can hear you. Let's have the slides.
I have a slide spread. Do you have it there?
Yes.
Okay, can you just show it so that everybody can go along with me? So what we just want to emphasize on is that we need to understand that over 70% of the dietary sodium we are talking about comes from eating packaged and prepared foods. So that means you work on what the patient is eating. So, and then we also need to now make sure that we need to find a way to reduce how that packaged food should be reduced in their diet. So what is the recommendation? That is not so easy, but we just have few points on how to easily achieve that, so that you have this thing to always tell your patient on how to achieve low salt. One, we are saying that they should make their food on their own. They should have to eat more homemade food, because when you go to restaurants, they are not considering whether you are diabetic patient. All they after is the taste, and for the taste to come out, they must meet up with most of the population. So they're not considered of reducing having low sodium or not like that. So the patient should eat more of homemade food, and that is better. Then the habit of forming the habit of putting salt discourage all the time, and at the same time we should always advise them to make sure that salt should be the last thing they put when they are cooking. So that will be able to allow the reduction in their salt use. So number 2 point is for them, the season and to rinse it. You encourage most of the patients to have more of natural herbs and spices to enhance the taste of their food, like them including more of onions, garlic, ginger, and thyme into their food, so that will taste. And at the same time, for any canned food or vegetables they are taking, because most of the vegetables and fish are being preserved with salt and then oil. So we always encourage that they at least rinse it out before they use, and they reduce any form of canned food or cubes. Then you also advise them to eat fresh. Eating fresh saves them from using much of the salt and clean. So eating fresh and unprocessed fruits, vegetables, whole grain, cereals, and meals. Then patients will learn to read labels. You having 140 milligram of sodium in your food or in any food you want to buy is higher. So they should learn to always reduce it. So what are the practical tips you need to tell the patient to increase their fruits and vegetables? Now, the actual recommendation is you having 5 or more fruits and vegetables. So how do you achieve that? You achieve it by starting.
You're on mute, Mrs. Fumi. You are on mute.
Wow, sorry. Okay, so all you just need to do is practical tips to increase your fruits and vegetable. So that means you need to always emphasize that, okay, make sure you have a favorite food, even if you have a favorite food, but make sure you pair it up with fruit or vegetable. So the number 2 tip is to always add fruits to your cereals, such as porridge or oatmeal instead of sugar. So because we also want to control the calorie, so we also need to also make sure that we have more of micronutrients in their diet, and at the same time increase the fiber in their food. So it's a very good way. Fruits and vegetables can be used to increase the fiber in their food, and at the same time ensure more micronutrients. So putting it in their cereal is an ideal thing to do. So we also try to encourage to bring fruits and vegetables as the on-go snacks. When they want to snack, the first thing they should think of is fruits. They should have carrots in their bag, cucumber, garden egg. You don't need to cut them. So they should always have it as a snack to always eat. Then they should always ensure that lunch and dinner are served with vegetables. This will help them to increase the number of servings they have in the day. The last use vegetable as the main ingredient. Now, we can always make sure that something like giving an example of rather than having high ingredients. So the last point is for you to use fruits and vegetables to garnish your food, to use it as a topping, as a sauce, or as a filling. So we must also emphasize that this is very important, just like what doctor said, that vegetables like terere, water leaf, manuga being added to the meal is very, very important in management of this hypertension. Thank you.
Thank you very much, Mrs. Fumi. I'll take a few questions, and there are a few on the chat. If I can read out the first one. Over to you, Dr. Wafula. Why should the systolic blood pressure not go below 120 mmHg for an individual less than 65 years with hypertension and/or diabetes?
There are studies that have been done about tight blood pressure control. So there are what we call points of inflection. There's a point blood pressure at which you derive a benefit. So the management is not primarily about the figure, but is about the benefit of a particular level of blood pressure control. That's number one. Number two, for you to be able to bring someone, for example, from 160 to 120, the pill burden is likely to be very going to be, and the cost of care is going to be very high. So if you consider the cost of care, if you consider the risk of side effects, if you consider the morbidity, mortality risk of very, very tight control and organ dysfunction, then you do not want to go below where evidence shows benefit.
Okay, thank you for that. And there's another question. A client with generalized edema and BP of 120/100 should be managed how do you manage such a patient in a primary healthcare level?
That's a patient who requires evaluation. The question is, why do they have generalized edema? One of the commonest causes of someone to have such significant fluid retention is kidney disease. You can have pure kidney disease. You can have a mix of cardiac and kidney disease. Okay, you can have a mix of pulmonary, cardiac, and kidney disease. So that's a patient who cannot be kept at a primary care level. That's a patient whose care needs to be escalated. That patient will require renal evaluation. That's a patient who will need cardiac evaluation. And that kind of evaluation is not very common at the primary care setting. So it will be important to notice that it's a severe patient and refer them to where they can get care.
Okay, thank you, Dr. Wafula. I'd like to encourage everyone who joined during the lecture to please introduce themselves on the chat. Give us your name and the facility that you're coming from. So for now, we'll move to the question, which is a case presentation. And this will be made by Dr. Rita Nabwire, Resident Medical Officer at Kisumu Heart Center. Karibu Daktari.
Thank you. Good evening, all. I will make a case presentation of a patient who presented to our facility. The patient's name is GAA, a 79-year-old male who was admitted on 7th of July and discharged on 10th of July this year. Next slide. The patient is a non-diabetic hypertensive patient who was on oral Anjeza HT once daily and Nebulong 5 milligrams once daily. He presented with dizziness and fatigability for a month. History of presenting illness, the patient had dizziness that was associated with near syncope, easy fatigability associated with occasional shortness of breath on exertion, polyuria associated with nocturia, urgency, frequency, and nocturia, and lower limb numbness with occasional heartburn. On examination, this was a stable patient with a slow regular pulse. S1, S2 was had, there were no murmurs. 2 BP readings were made. The first one, a systolic of 184 over diastolic of 84 with a pulse rate of 52 breaths per minute. For the second reading, a systolic of 166 with a diastolic of 78, a pulse rate of 47 breaths per minute. SpO2 was 98%. BMI of the patient was 28. So an impression of systemic bradycardia secondary to beta blocker and control hypertension, diabetes to rule out benign prostate hyperplasia was made. So plan for the patient was to admit, perform echo ECG, HbA1c, UECs, lipid profile, PSA, TFTs, troponin I, D-dimers, and complete blood count. The results were as follows. Significantly, there was sinus bradycardia on ECG. Echo showed a hypertensive heart disease with moderate mitral regurgitation. EF was 55%. PSA was elevated above 100 nanograms per ml. Troponin I was at less than 0.10. D-dimer of 220. Lipid profile results were as shown. TFTs were normal. HbA1c was elevated. We had 7.64% with an RBS of 7.2 millimoles per liter. eGFR was reduced at 20 mLs per minute per body surface area. Sodium was 126 millimoles per liter. potassium was at 5.01 millimoles per liter. So at 2:55 p.m., the patient was admitted to the ward with a diagnosis of CKD-DM, hypertension with benign prostate hyperplasia to rule out cancer of the prostate. 2 more readings were done. The first one had a systolic of 191 with a diastolic of 89, a pulse rate of 55 beats per minute. The second reading had a systolic of 193 with a diastolic of 85 beats per minute. So the plan was to do a prostate ultrasound, to give per oral Prostaflo 7 one tab once daily, give amlodipine 10 milligrams once daily, oral losartan H 1 tab once daily, and to observe for sugars and blood pressure. At 6:30 p.m., urethral catheterization was done where 1.5 liters of urine was drained. So a diagnosis of bladder outlet obstruction secondary to BPH in a diabetic hypertensive patient was made. The patient was put on per oral tramadol 50 mg BD and Jackson 2 grams per day. The following day at 9 p.m., the patient complained of hematuria, but was otherwise feeling better. A repeat UECs was done. EGFR of that day was at 17 mL per minute per body surface area. Patient was doing well. BP that day was systolic of 168 with a diastolic of 81. RBS was at 7.4 millimoles per liter. So the plan for the day was to have a urologist review. MCU was done, which showed significant postvoidal urine volume and elongated splayed prostatic urethra. So that is the end of the case presentation. So your comments and recommendation are welcome. How would you manage this patient? What is your evaluation? What would be your choices of drugs, and what would be your consideration for the choices you make? Thank you.
Many thanks, Dr. Rita, for the insightful presentation. So we will now allow a couple of questions for questions and answer, a couple of minutes for questions and answer. And perhaps to pick it up from where you left, how would you manage the patient if it were you? And what would your choice of drugs have been and why? I'd like to allow any hub experts who's around to unmute themselves and share their thoughts. Okay, fine. I think we'll move on to a couple of questions on the chat. How can we manage a patient with systolic pressure within normal range and a consistently low diastolic pressure while being careful not to raise the diastolic by increasing the patient's sodium intake? For example, a BP of 137/50. Dr. Afula, if you're around, I'm throwing this to you.
Yeah, thank you. Can you hear me?
Yes.
That's an interesting patient, because when you have a wide pulse pressure, the difference between systolic and diastolic pressure, that patient requires evaluation. That patient requires evaluation. Why do you have such a big difference between the two? So that's a patient who would best be managed. First of all, I would not panic about doing anything. If the patient is on medication, I'll let the medications be. But I'd want this patient to be reviewed at a higher center. Most probably they have a condition like aortic regurgitation. Maybe they even have hyperthyroidism that is not known. So that's a patient who will not remain at a primary healthcare facility. This is a patient who needs cardio.
Okay, thank you. There's another question from Ben Yoni. Can a patient with history of high blood pressure for years, but controlled with medication down to 130/85, reduce their medication over time?
Yes, it's called a titration. Remember, when I talked about barriers to control, one of the problems we had is inertia, a slowness, a sluggishness to adjust the dose of medication. So if a patient has been well controlled and the blood pressure is adequately controlled, under controlled situations and under a watchful eye, the doses can be de-escalated, or the burden of drugs. We can start removing some drugs, keeping in mind compelling indications, the reasons why you started the medication, keeping in mind the complications that necessitated those particular medications. So you don't look at just the blood pressure figure, you look at the patient in totality. For instance, if a patient has had hypertension and they have developed dilated cardiomyopathy, their heart has become weak and flabby, and they had an episode of heart failure and they have compensated, they will need a set of drugs for them to live well. For example, they may need an enalapril, an SE inhibitor. They may need a mineralocorticoid, aldactone. They may need a beta blocker, atenolol or carvedilol or an abivolol. And they may need a low dose of a diuretic to sustain them. So there are reasons why you may de-escalate the medication, but there are also reasons why you may need to keep certain combinations together. It's important, therefore, to discuss that with a colleague who has more experience and who understands that patient very well.
Thank you, Dr. Afula. Any other questions from the participants? You can unmute yourself and ask. Is there any other question or comment from the participants? Feel free to.
There's a patient, there's someone who is asking, how is the diagnosis of blood outlet obstruction made? This is a patient who was seen in the A&E for a very high blood pressure, low pulse, and was admitted for evaluation. It's during the course of the night that we were called that the patient is unable to pass urine. The patient was unable to pass urine. On examination, we found a markedly distended bladder, and it was important that we drain that urine to relieve the patient of pain and to protect the kidneys. The thought of bladder outlet obstruction was entertained. Concerning the PSA, there are many reasons why PSA may be elevated. After intercourse, it may be elevated. Prostatitis, it may be elevated. A very huge prostate, benign prostatic enlargement, it may be elevated. Cancer of the prostate, it may be elevated. So once we found that the patient had acute urinary obstruction, we had an ultrasound done that showed a massive prostate, and we actually called a urologist to take over from there. The patient actually had prostatectomy done. Thank you.
Thank you, Dr. Afula. Any other questions or comments?
Rosemary Wanjiru has her hand up.
Oh, Rosemary, kindly go ahead.
Thank you very much. That was a very interesting talk, Dr. Wafula, and an interesting case. Being an endocrinologist, I would just like to point out on this patient who seems to be end-stage renal disease, and to just inform the participants that this is a patient we need to be very careful on the drugs that we're going to use. We know sulfonylureas are usually the commonest that are widely available, and metformin, but this is a patient who would need to avoid metformin because the eGFR is less than 30 due to the risk of lactic acidosis. And also the sulfonylureas, there's a risk of hypoglycemia. So this is a patient who I would want to put even in a facility where you're available, put them on DPP-4 inhibitors if you have linagliptin, which doesn't need dose adjustment. But if you don't have linagliptin, you can use the other DPP-4 inhibitors and dose adjust them. And also you can use a basal or intermediate insulin. Being elderly, I would not be very aggressive to bring in the HbA1c less than 7%. HbA1c of between 7 to 8.5% would be excellent. So these are very interesting cases, and is one of the cases that patients that we usually find, and a multidisciplinary approach is always the best. Thank you, Dr. Wafula and the team.
Thank you,
Actually, the reason why we chose this patient is just to highlight the fact that the older patient is not a straightforward patient. A 55-year-old patient, a 65-year-old patient is not a patient you want to manage secretively, you want to manage privately. It's a collaborative effort. And you need to think broadly about how to approach the care of that particular patient. If you look at this patient, the blood pressure is very high, the pulse is very low. You cannot use a beta blocker in this patient because then the pulse will go even much lower. Using an AC inhibitor, using an ARB, losartan or enalapril, or even a mineralocorticoid with a raised potassium, you risk severe hyperkalemia. So if you notice, the patient also had hyponatremia. So this is a patient you need to manage as a team. You need to be easy, you need to be flexible to refer these particular patients. I know there's a protectionist tendency among medical practitioners to be able to keep those patients, but it's collaborative. If I need a urologist, I need to engage a urologist. If I need a nephrologist, I need to engage a nephrologist. It's very, very important to build those teams. To be able to work on the electrolytes, I need a nutritionist to be able to advise on the food that would give me the benefit that I need. Thank you very much.
Thank you, Dr. Wafula, and thank you to all the participants. I believe you all learned something. So at this point, we'll now launch the quiz, the post-session quiz. Kindly ensure that you take it. Thank you. participants, I hope you're still continuing with the quiz. Kindly ensure that you take the quiz and gauge your knowledge gain. We have 7 of us who have completed the quiz. Kindly note that you have around 5 more minutes to go.
Some celebration.
Twelve of us have already completed the test, the quiz. Thank you. The rest, let's finish it.
Can we have a few more people vote, filling in the quiz? The numbers are still very low, just like Angela said. All right, we will give 1 more minute for response to the poll. Okay, just a few seconds left. Right. Thank you so much. We've been able to get a response of 42%, which is fine. Okay. Dr. Wafula, are you still here with us?
Yes, yes, I am. So may I continue?
I will just hasten to add that we are really running short of time, but I will allow you just to very quickly give the answers to the questions.
So in question 1, all the answers are true. High blood pressure is a leading risk of death. It's associated with 10% of total deaths, acute stroke, and dementia. So we need to be aware that it's a big problem and address it as such. Next is the second question. Which of the following is true? The first answer is true. The second answer is true. Third is true. The last one is false. Aging, urbanization, and westernized diets are risk factors. 3, which of the following are non-modifiable risk factors? The answer is the first one. You can't change someone's age, sex, heredity, or ethnicity. So you need to be aware in your community which of those are contributing to the burden of disease in your area. Which of the following is not a socio-economic complication? You got the answer right. Decreased cost of care. We know that there is increased cost of care. Which of the following is not useful in managing hypertension? We have 2 answers there. The first one is increasing weight. Increasing weight is not useful. We want people to reduce their weight. The second one, we do not want people to mix medications. We want people to use evidence-based approaches. Even if they are herbal medications, but they need to be documented to work. Which is the most important tool in making a diagnosis of hypertension? History and examination, correct. Which of the following is not a class of hypertension drugs? Alpha reductase inhibitors. The others are classes of antihypertensives. D, in managing hypertension, which of the following are important factors to consider? Cost and availability, correct. Convenience of the medication, whether it is single versus fixed dose combination, important. Compelling indications, like certain drugs need to be used in patients with hypertension. The risk of complications, like our patient already had raised potassium, so using drugs that increase potassium would not be advised. And then need for personalized regular reviews. So you need to treat each patient uniquely. So all the answers were correct. You need to consider all those factors. Which of the following is true of drugs used to control hypertension? A is true, B is true, C is true, D is true. All the answers are actually true. And the last one, which of the following is useful for controlling the burden of hypertension? All the answers are true. Increase physical activity, legislate salt and calorie content of food, enhance support to those who want to quit harmful activities, increase the pool of human resource who can detect and manage hypertension, increase access to cost-effective medications and devices like BP machines, and increase community engagement. All the answers were true. Thank you.
Thank you so much, Dr. Wafula. That was really, really useful, and I'm sure everybody who's been logged in has found your presentation, the case presentation, and the question and answer series, plus the quiz, very useful going forward. Thank you for taking the quiz. And right now, I'll just like to let you know that going forward, the Tele-education series is extending beyond non-communicable diseases to cover more population and health system strengthening topics. So TeNEC will now be called TECLA, which is easier to remember, and it stands for Tele-education for Clinicians and Leaders in Africa, all encompassing. TECLA, Tele-education for Clinicians and Leaders in Africa. Our next event will be on Thursday, the 26th of August, and the topic will be diabetes in pregnancy. Is the buck worse than the bite? Diabetes in pregnancy. Is the buck worse than the bite? It will be presented and hosted by Jacaranda Maternity, and the time will be 4:30 p.m. East African time, which will be 2:30 p.m. West African time. Please make time to attend that, invite others to join, and if you have any other topics you would like us to present in future, very quickly feel free to post these on the chat before you log off. You can also share these on our social media pages. And once again, these are our social media handles. Please leave that slide on. Thank you. On behalf of our partners and everyone who's been part of today's organization and presentation, I wish to sincerely thank each one of you for joining us. We hope to see you at our future events, and most certainly on August the 26th. Thank you. Could we unmute and just give ourselves a clap for turning up and being here? And say something.
Thank you. Thank you, Dr. Wafula. Thank you, everybody.
Well done.
Our absolute pleasure.
Thank you. Well presented.
Thank you.
Clap, clap, clap.
Hi, thanks for the section.
The topic of mental health. Okay. One recommend there. Let me open this one. This one is locked on this side. It's open.
All right. You can post any topics you'd like covered in the future. Meanwhile, now you can leave at your leisure.